This is Seeds Podcast, bringing you tips, conversations, and information about applied behavior analysis.
Everybody, welcome back to another episode of Let's Talk ABA, a podcast by Seed Autism Services. Today, we are very, very fortunate to have Dr. Rajini, consultant and developmental pediatrician. I think Dr. Rajini is very well known to a lot of us, audience on this podcast. So today, we are hoping to talk to Dr. Rajini about some updates about autism. Welcome, Dr. Rajini. How are you today?
I'm fine, thanks, Alexa. Thank you for having me on.
Well, thank you for spending time with us amidst your busy schedule. So, Dr. Rajini, today we really would like to have a chat with you about current research about autism. So just a premise for our audience, we would like to, the goal today is really to unpack some of the deeper questions about autism. So I think as service providers and as people who serve the families who are impacted by autism, I think every year, we try to educate the community and try to demystify autism. And I think people have been catching up in terms of having the awareness about what is autism. And we are all now start to be quite familiar about the core symptoms of autism or some red flags to look out for. Teachers are starting to pick out some of these red flags earlier and start to refer perhaps to you to let parents know and then refer to services. So I think over the past 10 years, it is picking up. But today, we really want to dig a little bit deeper into this diagnosis and really look at it from the neurodevelopmental perspective. So the brain, for the definition of the neurodevelopmental definition. So with that in mind, perhaps I should ask you the biggest and the broadest question first. What has been the most current findings about autism as a neurodevelopmental disorder?
I think, if we look at it in terms of first, maybe what a lot of times, I'm going by how I approach it clinically with patients, and a lot of times parents ask me, why does my child have autism? So the etiology of it, or what may be some of the causative factors. I think, there's been a lot of research looking at that. And then there's also the aspect of identification and early identification, actually, Alexa. I think there's been a lot more research in this last sort of 5 to 10 years looking also at early intervention. And when we mean early intervention, we're even talking about infancy and that early toddler phase when children are around 1 to 2 years old, and how early intervention can really help change the trajectory of the development of symptoms in some children. So I think if we talk about current research, I think if we focus a little bit on etiology. So you're right, it's a neurobiological disorder. What do we mean by that? We actually know that there are changes in the brain.
Right.
Yeah. And that evidence comes from, in the early years, how people looked at what the brain, how the brain changes is by measuring head circumference. How big your head is.
Okay.
Yeah. Okay.
Oh, is that? Okay. So yeah, because I just have a baby, and every month they will measure. So that's what it's for.
Yes. Okay. Right. Because that used to tell us how infants or a child's brain grows. Yeah. And actually, early research showed that in some children with autism, there is rapid head development in comparison with their physical growth, their height and weight, or their length and weight. Okay, so and then came imaging studies. So imaging studies, we mean looking at CT scans, MRI scans as time went on, and people were measuring the size of the brain in terms of volume. And research, there was research that showed through MRI studies that yes, the volume of the cerebrum, or the main part of the brain that controls movement, actions, etc., is bigger in children with autism than children without autism. And then came what we call functional MRI studies. So functional MRI studies looks at how brain functions, and how they measure the function of the brain is through the various chemicals that are present in the brain, and how that changes, or the activation of the brain during certain activities, etc. Okay, so parents always ask me, can we do functional MRIs? But to be honest, a lot of functional MRI studies are done for the purposes of research. Right. So even in countries like the US or in developed countries, functional MRIs are not routine. Studies have actually shown us how things change in the brain. And then we also have EEG studies. So EEG studies are where, for the layman, it's where you see people put little wires or a little cap with wires on the head, and they look at brainwave activity. Yeah. And this, the use of EEG in association with, for example, facial recognition. So there are studies looking at how babies recognize faces, etc., and then they look at brainwave activity to see how it matches. These also provide evidence that this is a neurobiological disorder. Okay, so I think in the past, people talked about the cold mother and the fact that it's to do solely with parenting, etc. I think that we can do away with that. But what is clear in current research is that in autism, you are born with genes that predispose you to developing autism, and it's that interplay of that gene susceptibility with the environment that you're in that determines whether or not you develop the symptoms of autism.
I see. Okay.
So it is a genetic disorder, right, but it's not as straightforward in that, in some cases, yes, it may be. So those tend to be the syndromic autism cases that we talk about, where there are specific genes that are inherited. If I give you an example, would be something like Fragile X. Some children with Fragile X have symptoms of autism spectrum disorder. Or if we look at certain genetic deletions that are clearly associated with autism, and if in that family more than one child has that genetic deletion, we see that they also have symptoms of autism. So it's a genetic disorder, and we know that, and that influences how your brain develops, and it's also the interplay of environment that decides how much of the symptoms you exhibit.
Right. So just to recap, so for now, there has been advances in first early diagnosis. So when we talk about early diagnosis, is it as early as you mentioned, 1 to 2 years old, between 1 to 2? Because previously we've heard that 2 years old and above, right? People are more comfortable with diagnosing then, but now it seems like we can actually pick it out earlier, right?
Yes.
And that would help with early intervention, so we can intervene earlier, and that would affect better outcomes.
Yes.
Right.
And I think a lot of that has been proven through research. So studies looking mostly at siblings of a child who has been diagnosed with autism and following up the siblings where from infancy.
Mhm.
And we now know that there are red flags. Yeah. So we may not diagnose autism in a 1-year-old, but there are strong red flags that will predict a diagnosis of autism, and we try and look out for these to intervene. So hopefully we don't actually have to diagnose autism later on.
Right. So once you
If that makes sense.
we may not even need a diagnosis later on because we have already
Yes.
intervened. Okay,
Yes.
awesome. Okay, that's good news, right?
Yes.
Really, really helpful for a lot of people. And then when we talk about the
Yes.
advances of how people start to view autism as a brain can I say brain disorder, a neurodevelopmental disorder is, so from head circumference, it sounds like people are looking from outside to deeper into the volume, and then now the activity of the brain, you can even pick it out from then on. And you mentioned about genetics. So to put it in sequence, so it's the genetic part may predispose, that affects functions of the brain. Am I right?
Yeah. Yes.
That predispose how the brain function, and then that may lead to a diagnosis of autism, and then the behavior, right? That's what we see on the outside.
Yes.
Right?
Yes, that's right.
Then there's another subset where you could actually pick out a very specific genes like Fragile X and other gene deletion, right? So then, so thanks. That was a really clear picture about where we're at now in terms of looking at etiology of autism. Then that leads to a question of diagnosis, right? So do people use, for example, EEG? But it sounds like EEG look at a very specific, like you mentioned, face recognition, very specific skill. Are people starting to look at using these as some of the diagnosis? If we could kind of like and all,
Yeah, so I think what's important to understand is that autism is a spectrum, right? So when you're looking at even things like functional MRIs or EEGs, there are specific things that we look out for in certain parts of the brain to look at brain function to see whether there are diagnosed autism. But these are not used as diagnostic tools per se, for a variety of reasons, because number one, it's a cost issue. And as we mentioned, it's a spectrum. So there's no one specific change that would tell us, this is what we look for to diagnose autism. Yeah. And doing something like EEGs or MRIs or requires a lot of technical, specific training in reading some of these, right? That's one. Number two, if we look at other biological markers like chemicals in the blood, or, again, there's a variation. Yeah. So it's not so easy to sort of pinpoint, we only look at serotonin or we only look at dopamine or, specific chemical markers or oxytocin to tell us that this child is going to have autism. And it's because it's a disease that's a spectrum. Yeah. So that makes it more difficult. And hence why when we look at the diagnosis of autism currently, it is still looking at the behaviors that a child exhibits, or even an adult exhibits, that leads us to diagnosing that problem.
Right.
Yeah.
Right. Thanks. So that leads us to a lot of parents. They come to us and ask, what can they expect? So, for example, in your clinic, what can they expect during the process of diagnosis?
Yeah. So, the process of diagnosis involves clinical examination first. For example, we will look out to make sure that that child who walks in through the door, doesn't have to do that. We do that by examining them, looking out for certain features. For certain genetic conditions, that child may look a little bit different. And that difference may be subtle. So it may not be so clear to a layperson. And it's a combination of signs again, So if you look at us diagnosing Down syndrome, how do we go about diagnosing that? Well, yes, there may be genetic markers in pregnancy, but when a baby is born, and previously we didn't suspect Down syndrome, but the first thing that alerts us is that that child looks different. So in autism, in some syndromes, it may be obvious that there's a difference, but in many, it is not so obvious. But we look out for those genetic signs or syndromic signs. We also would want to do a neurological examination. Now, I have to make it clear to parents that sometimes majority of a neurological examination is actually observing a child move. So how they walk around the room, how they use their hands, are they using both sides of the body equally? Is there any stiffness and things like that? And then of course we bring out our equipment where we use our stethoscope to listen to the heart, and parents often ask, why are you doing that? Because we want to look out for other abnormalities that sometimes coexist in certain syndromes. We also bring out our tendon hammers where we, check for reflexes to look out for any neurological issues. Sometimes we also would want to do more testing, but that's not in all children. So that's looking at the evaluation from a medical perspective. Then there is also the evaluation in terms of developmental observations. So, that's looking at how a child plays. Do they have any repetitive behaviors when they get excited? So we may bring out things like bubbles. We may bring out toys that we think may trigger excitement, and then look at a child's response, because not all children have persistent or pervasive repetitive behavior. Some only produce those repetitive behaviors when they're excited or they're scared, And then we also would want to assess what the child's abilities are in terms of their motor skills, so we're looking at the gross motor, the fine motor, how they manipulate things. Do they have pretend play or play that's appropriate to their age? How they respond socially with us. And for a lot of us pediatricians who are involved in assessing children, we rely a lot on home videos, because what we see in the clinic setting is a very snapshot view, and some children are uncomfortable with that. But when parents show us videos, that gives us an idea of how they're functioning at home as well.
And that's the natural environment.
Exactly. And sometimes we also take into account what teachers' observations are for the children who are already going to childcare or preschools, etc.
Okay, so it's very thorough. It sounds like once they walk in, the medical examination, then the developmental observation, and then skills, right? You were talking about fine motor, gross motor. So all these things, all of them have to be taken into account, right? What about... Sorry. Go ahead.
Sorry, I should add in that as we're doing that, we may also be doing a questionnaire, or we may also be using specific tools to score these behaviors. So there's a number of tools out there that we would use, like the Childhood Autism Rating Scale, or the Gilliam Autism Scale, or the gold standard, the Autism Diagnostic Observation Schedule. But some of these take a long time, and that's why going in to make that diagnosis is not a 20-minute sort of observation interview. It takes longer than that.
Right. What about IQ test? Can I? What is that very relevant? Is it something that it's a standard thing to look out for in diagnosing autism, or is based on after all these observations, if there's a need that you feel, then only there's an add-on to that?
Yeah. So, how do you assess IQ? So IQ is looking specifically at cognitive skills, right?
Yeah.
So, how we like to look at, so we know in children with autism, they are going to have communication difficulties. So we look at components of IQ per se. There's the nonverbal component of IQ, so that the cognitive abilities, regardless of their language abilities, and then there's the verbal component or the language component of IQ, and understanding IQ is, it's not just about that number.
Yeah.
The IQ is normal or the IQ is above 70, etc. It's also looking at how they process information, how they reason things as well. So if you're talking about IQ tests per se, specific IQ tests, we tend to recommend that children do IQ tests if we are really not able to ascertain their abilities, or there's a mismatch in skills.
Okay.
That's very obvious. So if you're talking about children under the age of 5, majority of the developmental assessments that are done is able to give you some idea about that child's cognitive ability. Okay. So, and that child's ability to learn. If we're talking about children above 5, then we do probably need to do more cognitive testing, especially, like I said, when there is a mismatch in skills. So we find that, they're really good in certain areas. For example, reading. They can read really well, but why is it that they can't process information so well? So then we may need to refer them on for an IQ test to see what is going on there. Or for some of the borderline children, or when we're looking at placement of school, when the school readiness testing that we do doesn't give us enough information.
Okay.
But I would say not ideally, of course, in the ideal situation, we want this for every child. But if we're talking about resources and accessibility to such testing, it's very, very costly and time consuming, and it's not so very readily available, I would say.
Right. So when you suspect there's a mismatch, that's when you will refer for an IQ test. Right. Okay. Then the other part of it sounds like the diagnosis process is we would really, is thorough. But then there's also, so we rely parents, if they could bring videos for to the appointment, that would make it a lot more efficient. And then there are so many aspects to it, right? And the other question then is, if parents have or teachers have suspect and picked out, and before they could get an appointment for a diagnosis, how is gaining diagnosis important before we start intervening? Because some parents, there are clear skills deficit already. Could we go in and work on this first while waiting for an appointment for diagnosis? What are the pros and cons to it? And there are also, we sometimes parents ask, okay, so we've already started while waiting for an appointment. Is it still important to follow through with the appointment like 6 months later to get a diagnosis? But since we've already started doing some things to try to intervene.
Yeah, I think, I think we shouldn't wait for a formal diagnostic evaluation. If we suspect that a child has any delays or impairments in their development, I think we should intervene at that point. Yeah. And I always say this, that intervention does not always have to mean you must see therapists to intervene. Sometimes it's about changing behaviors at home. It's about educating parents. So this is where therapists play a role as well, yeah, in parent education and what can be done at home. So I would say that intervention should start as soon as we are concerned about a delay or an impairment or something that's not following the normal range of development. So it's about ensuring that that child is being assessed holistically and we don't just focus on one aspect of it. So intervention should start early because, like I said, for a lot of infants and toddlers, it can be difficult to make that diagnosis straight away. In some, it is so clear-cut that we can even give them a formal diagnosis as young as 18 months. But then what about the children that we already pick up red flags at 12 months? We're not just going to wait and not do anything. So intervention should start. Is it important to then have a formal diagnostic evaluation? I think it is. And I think for the very reason that we want to be sure that that child's making progress. We want to know what else should we do to intervene. And sometimes having that evaluation process allows for that.
Because the process is quite holistic. It's quite thorough. Okay.
And in some way, we also want to see whether we can identify any causative factors. So if that family is planning for the next child, what are we going to do with the next child? You can look at it as prevention. We're not saying that, we're going to do the genetic testing, identify the gene, because the reality is there's so many genes involved in autism. But what we're going to say is give mom advice. Okay, in pregnancy, what can you do? There are certain things that people have found now. For example, folic acid supplementation is important in prevention. However, we don't want to overdo it either. For example, monitoring mothers during pregnancy, because again, one of the research that's looking into the etiology of autism is looking at, maternal infections when they're pregnant. So we want to alert parents that there are things that you can do while you're pregnant, after the baby's born, how we track that baby's development subsequently. So there's a variety of reasons why intervention is important. As you mentioned before, Alexa, early intervention can sometimes help. So eventually that child doesn't have a formal diagnosis of autism, but we may pick up other subtle developmental disorders that may accompany it. And it also forms a baseline so that later on, if there are issues, we can look back and see, okay, maybe there was some signs early on, but they were not impacting the child, but it's showing itself now. So there's a variety of reasons why having a formal evaluation.
Right. Well, as you're talking about this, it just reminds me of you're very spot on, because I just very recently had a conversation with a parent because of the pandemic. So when they don't have access to appointments and diagnosis, but they did pick up on some developmental delays in the child, and that at the start of the pandemic, the child was only 18 months, and the parents already started to change some things, the way they do things at home to try to promote more language development and social development. And now we can come out and seek help. Now they're starting to look for services and then look for a diagnosis. But that 2 years was so crucial that when they came to us, and I was just looking at the child thinking, well, if he has a diagnosis, he probably is at borderline. before the mom told us about history, I didn't pick out that he could, so 2 years before he could have that diagnosis. So yeah. So that's so it picked out early intervention, started to do something at home that would really help, and then for further evaluation to kind of, because when we have the conversation with the parent, it's also about whether, now that he's in school, he's thriving, he can actually enter, he's doing really well in his academic, but we did pick out that some social piece, a social communication piece. So then the question becomes, is it still important to get an evaluation, diagnosis? But that's really spot on getting that will then inform how, I guess, he can continue on in his learning journey moving forward, and also explain what was going on 2 years before.
Yeah. And also, I think what we've seen over the years is that many children improve with early intervention, especially more intensive intervention in the first few years of life. So much so that when they enter school, you can't really see that the difficulties are there. However, and I always say this age of, when they become tweens, so that 10-year-old phase where social demands start to escalate. Children start to be a little bit mean, a little bit stresses come in. We sometimes see some of those autistic behaviors escalating again. So having that diagnosis early on can sometimes remind parents to keep a lookout, so that before they become major issues, that intervention can take place again. And I think that is something that at least I've had feedback from parents that they were glad that they did the early intervention. They were glad that we reminded them that, yes, the diagnosis still holds, even though intervention happened, because at least they were able to, monitor their own children and seek help early later on.
Yeah. And prepare for, like you said, more social demands in the future. Right.
Yeah.
And it is the biggest challenge for the autism population is the social demand. Right.
Yeah.
Right. Awesome. Thank you for that. And the other thing is, since we're talking about the brain changes and all, I can't help but think about medication, because for what I medication changes some chemicals in the brain. And so can you just let us know what are some of the common medication prescribed to children with autism? How do they help? I know there's no medication that stop autism or cure autism, but they target certain certain challenges, right? So what are some of the for now most updated medication that's being prescribed to children with autism?
So one thing I always say to parents is medication alone is never going to help manage the issues that we're targeting. So managing any issue when we're thinking about using medication goes hand in hand with behavioral intervention. Yeah. So if we look at this of autism without other comorbidities, we would only use medication in children who may be exhibiting some self-injurious behavior, where they're harming themselves, or as a result of agitation or irritability, they may harm others. Often quite rare, but it does happen as well, where they are not able to manage their emotions very well to regulate themselves. So like I said, we would use medication when we've exhausted behavioral interventions, or to aid behavioral interventions, and to also sometimes improve quality of life. Yeah. Where the parents are struggling, family life is being affected, etc. So there's a variety of reasons. So one such medication would be risperidone or aripiprazole. So these are, I know it sounds horrible, these are antipsychotic medications because traditionally they were developed in the usage of treating schizophrenia. However, in lower doses, we do find it, and this is evidence-based, it does help with irritability, agitation, and self-injurious behavior. We would try not to use such medications in children under the age of 6, again, unless they are causing harm to themselves or to others around them. Yeah. We often find that we need to use these medications, these antipsychotic medications, in the pubertal period. So when puberty hits, when there's a change in hormones, and when we are struggling with behavioral interventions to help children manage their emotions and regulation.
That's interesting. Is it because during the pubertal period, because of the hormonal changes, hence the behavior changes? Hence, sometimes we may need medication to aid those chemistry that's going on in the body to help bring down those behaviors, and then we can learn better.
Yeah. I mean, we must remember that, even if you look at typically developing children, when they hit those teenage years, I always say this to parents, as a mother, I got the door slamming, impulsive behavior comes out, testosterone, the emotional lability, the testosterone, estrogens, that does that to your brain. In children who are able to regulate themselves better, we don't need to use medication. But for a lot of children, sometimes they don't know what's happening to them. And it takes a while for behavioral interventions to kick in. And hence why preparing for puberty is very important. So, I think we would use medication then. The other more common medications that I use are often to address comorbid attention deficit hyperactive disorder, or ADHD. And we know that, in neurodevelopmental disorders, there's always an overlap of disorders. So we often see that ADHD coexists with autism. And if there are times when we feel the ADHD symptoms are probably more debilitating, and hence we would need to use medication to help manage the ADHD symptoms of attention deficit, impulsivity. So then we would use either stimulant medication. So an example of that would be methylphenidate, or many parents know it as Ritalin or Concerta in Malaysia. And then there's the non-stimulant medication, which is atomoxetine or Strattera. How we decide what medication to use would be based, again, on scientific evidence, what works best, and also looking at the individual child or adolescent to see what would suit them best, looking at whether they have any underlying issues that would contraindicate the usage of medication.
Right. Okay, so it sounds like not immediately prescribing medication. It's based on behavior intervention and all the other intervention first. But if that's comorbid, and the goal is really to help them regulate their emotions and behaviors so that they can start to learn, right? Like bring them to a place where they can, because without it, sometimes it could be so disruptive and self-harm, you self-injurious behaviors and all. We could not even start teaching them skills to regulate those.
Yes.
Right. Okay, thank you so much for that. Yeah. So it did answer the question of so they do change the brain chemicals in some ways to help them behaviorally. Okay.
Yeah.
Thank you for that. And also then comorbid just now when we were talking about comorbid disorders with autism, right? Bringing that back to diagnosis, is that also done together in the same observation, or?
Yeah, and when we're doing the diagnostic evaluation, we would always look out for comorbidities. Right. Yeah. Okay. Now, so comorbidities like ADHD, dyspraxia or developmental coordination disorder, whether there may be other conduct problems or even anxiety disorder. And what's important to understand is that not all comorbidities are present at the initial diagnosis. Yeah. Okay. So we sometimes we sometimes find that the diagnosis of ADHD comes in later, or the diagnosis of dyspraxia or developmental coordination disorder comes later, because not to say that it wasn't present at all before, but when we diagnose neurodevelopmental disorders, it's also based on how much it's impacting children functionally.
Right.
Okay. Right. So, we, and you may know this, Alexa, working with kids, right? You work on their strengths and their difficulties. And as they, and remember, the brain is changing. So, we talk about the fact that the brain is still developing and forming new connections, and based on our interventions, it is changing so that, so we call that neuroplasticity. It's remodeling itself based on interventions. But at the same time, because the brain is changing, sometimes we may find that other developmental disorders come to a head. Yeah. And also because of environmental factors.
Right.
So sometimes we tend to, because the child is achieving their motor milestones, we sort of focus a lot more on their deficits, which may be their social communication or their anxiety. Then as the child gets older, we start to realize, oh, he's actually, he can walk, he can run, he can jump, but his balance is off. And then we start to realize that his bilateral motor coordination is also affected. So then we start to see the features of dyspraxia coming in. Okay, so then if we don't work on that, it will affect them socially, because when they're playing in sports or something, they're clumsy or they're not very coordinated, and their friends say, "We don't want you on our team." So it's important, hence why we continually evaluate children. And I think this is sometimes difficult for parents to understand. Yeah. They think, okay, I've come for therapy. My child's doing well. He can learn. And that's the end of that. And I think it's very important that parents understand that this is an ongoing disorder. And that, other issues may crop up as well.
Right. And could it be also the, just now you mentioned the environment, not only the brain changes, the environment needs changes as they grow as well. Like they start to go into different kinds of social contexts. The environmental demands on them start to change as they go into different places. So then we start to see different kinds of things cropping up.
Yes, definitely.
And that makes it more obvious. Perhaps that could be something else when they were younger, but it just didn't, appear because there's demands for it. All right, great. And just like you mentioned, neuroplasticity, right?
Yes.
So our brain always change, especially I read that even now, even as adults, like when we learn new things, that also means um, different neurons are connecting as we're learning, right? So
Yes.
so then that made me think. So with children with autism as well, where we're doing different kinds of intervention, that means their brains are also changing as they are receiving interventions, right?
Yes.
Has there been, I'm not sure if you have, has there been research that has shown that as children with autism are receiving intervention, their brain is starting to, I'm not sure if that's the correct way to think about it, to become a little bit more like the neurotypical brain as they become more behaviorally, because we're teaching them to, what do you say? How do you behave? Has there been any research on that?
Yeah, and there have been lots of studies that you know use, like I said, functional MRIs, looking at the function of the brain before and after a period of intervention. There have also been EEG type changes that have been shown with, say, for example, facial recognition training. So a lot of this, we have enough scientific evidence from the functional MRIs, the EEGs, and also from day-to-day changes in a child's behavior. Yeah. And at the end of the day, it's more important that we see these functional changes in real life than just looking at the testing changes, if you know what I mean. Yeah. And we've seen that. And our earlier studies of neuroplasticity come from stroke rehabilitation.
Okay.
Yeah. Right. And we know that the younger person, so a person who has brain injury, whatever brain injury, whether it's from a stroke, infection of the brain, or trauma like road traffic accidents, of course, it depends on the extent of the injury, but also the younger brain is able to remodel or of the older brain.
Right.
Yeah. Okay.
More flexible.
It doesn't. Yeah. So yes.
Okay.
And that's why early intervention. We always talk about intervention as early as possible.
Right.
Yeah. Yeah. Because the younger the brain is, the more malleable or flexible that brain is to changes as well.
Right. So, all right. Thank you for that, Dr. Rajini. I think we have come to almost the end of this episode. I think what I have learned from this is the progression of how people have look into testing and researching the autism brain, and regardless of all these. Early intervention is important, because then at the end of the day, we want to see, we want to help these children and these people with autism to be able to function in their daily living, regardless of what's going on in the brain. And for parents out there, I think when we go in for diagnosis, videos will be very helpful for the clinicians, so that the diagnosis process can be a little bit more efficient. And I've also learned about the IQ tests. I think that was an insight that I didn't know about initially. Thank you so much, Dr. Rajini. Do you have any last thing that you would like to tell our audience about autism?
Yeah, I think, understanding that it's a disorder which involves genes and environment is so important. And hence why we encourage parents to do things at home, because parent intervention has been shown to actually really help children, because when your environment changes in your daily life, it has a bigger impact on the child. And the fact that the journey is a long one. And just as the brain is changing, the children's behaviors are going to change. And as you mentioned very rightly, Alexa, depending on the environment that they're in as well. So hence, we don't talk about cure. We talk about improving skills so that children can adapt functionally.
Yeah. And it's going to lead, the journey, it doesn't end at childhood. It's going to go into teens. We talk about puberty, even into adulthood as well.
Yes.
Right. Thank you so much, Dr. Rajini, once again for joining us in this episode of Let's Talk ABA, a podcast brought to you by Seed Autism Services. Thank you, Dr. Rajini.
Thanks, Alexa.
That was Dr. Rajini. We thank her once again for joining us at Seeds Podcast.